So this is something that we want to avoid at all costs. When patients come too late with either pre-thicycle or thicycle eyes, and then we are just left with nothing else to do for them. So we all know that the long-term use of systemic corticosteroids is no longer acceptable. And there is so much evidence supporting the efficacy of corticosteroid-sparing regimens, what we call as immunosuppressive therapy, in treating various entities. So in general, the rule of thumb is that if the inflammation cannot be controlled with less than 10 mg per day within 3 months, you need to think in terms of starting immunosuppressive medication. And many experts now believe that the maximum permissible dose is now 5 mg or less. So we know what the problems of steroids are: increased BP, exacerbation of diabetes, bone loss, redistribution of body fat, hirsutism, acne, metabolic changes, weight gain, and a variety of other issues. So pitfall number one, which I have found: premature labeling patients of uveitis as steroid failure. Sometimes we don't use the right drug, we don't use the right dose, and we don't use the right duration. So when you see various steroid options that are available, betamethasone, dexamethasone, methylprednisolone, I have often found that patients are either under-prescribed the drugs or they are not prescribed it for the right duration. Once they do not get better, they're simply labeled as steroid failure and then referred elsewhere. So when we do treat patients, we need to remember that both for topical as well as systemic steroids, it's important not to taper the drug too fast. So when you're giving systemic steroids, you need to reduce it by 10 mg a day, often weekly, and you can go on reducing it by week. And when you reach 7.5, you need to taper it over every month rather than just stopping it over the next week. So the first pitfall is not to taper it too fast and not to reduce the dose to a bare minimum too early. The second pitfall I found is that uveitis is very commonly caused by infections in India. Before you start immunosuppressives, you need to rule out the two commonest infections. One is, of course, tuberculosis by Mantoux, CT chest, and physician opinion. And second is syphilis by VDRL and FDA ABS before you even think of starting any immunosuppressive treatment. Pitfall number 3, not to recognize certain phenotypes. Certain uveitic entities like birdshot, VKH, which you can see on the left side, or Behçet's, which you can see on the right side, are all recurrent and severe forms and tend to be blinding. Birdshot, VKH, Behçet's, and serpiginous need early immunosuppressive treatment, and they are simply not going to respond to corticosteroids no matter how early or what dose you give. In all these phenotypes, you need to start immunosuppressive treatment as soon as possible. The next pitfall, the inability to recognize certain ocular complications, which means that either you are not treating them with adequate corticosteroids or the corticosteroids are not working and you need to elevate to a higher immunosuppression. These include progressive Seineke, steroid IOP rise, cataract, loss of RPE, visual field loss, and of course, some of the most common ones which we must not miss: capillary dropout and neovascularization, development of uveitic glaucoma, uveitic macular edema, inflammatory CNVMs. If you see any of these, this is a red flag that you need to elevate the treatment to immunosuppression. The next pitfall which I have found is incomplete monitoring. You need to evaluate these patients for any comorbid conditions, which sometimes they simply don't tell you because they don't think it's important. whether they've had any organ transplants in the past, any malignancies in the past, diabetes. Diabetes is, of course, the biggest problem because none of them are ever in control. They've not got investigated for a long time. Their age, their occupation, the history of travel, high-risk sexual activity, history of exposure to TB, history of blood transfusion. Ideally, we should even consider hepatitis B screening, hepatitis C screening, HIV screening, and most important of all, never initiate any patient on immunosuppressive treatment without thoroughly evaluating for the possibility of underlying tuberculosis in India. So you can do a MAN2, you can do interferon gamma, you can do chest X-ray, ideally to do a chest CT before you start anything at all. And the most important thing is, of course, let us learn to work together with rheumatologists to manage these patients. Thanks. I've just kept it short so that it could be easy.